Hey everyone, welcome back to another episode of the Brawn Body Health and Fitness Podcast. Today, I'm excited to welcome Keelan Enseki onto the podcast. Keelan is a physical therapist who really specializes in the hip joint at this point in his career, and he spent a lot of time researching the hip. So we're going to dive into some of his research and literature work today in the podcast. We're going to dive into some different examination and evaluation considerations. We're also going to discuss some return to sport considerations, as well as some general guides for interventions, because unfortunately, 3 sets of 10 sideline clamshells never changed anyone's life. I know you're going to love this episode. Be sure to check out all the amazing resources we have in the description below, including the links to Keelan's ResearchGate, and also be sure to check out the CPG that Keelan mentioned a few times during this episode as well. Enjoy. Keelan, welcome to the podcast. I'm super excited to work with you today.
Oh, great. Thanks for having me. Pleasure to be here.
Yeah, it's so funny how many people we share mutual connections with there. It's crazy how small this world really is once you get into it. And, everything I've heard from them is that you are kind of the guy when it comes to the hip, especially with hip and sports injuries. So would you mind kind of filling us in a little bit about who you are, how you got into the hip research, and kind of where you're at currently?
Yeah, sure. Great. Again, thanks for having me. I'm a physical therapist and athletic trainer, and I've over my little more than 20-year period of time, I've only worked in one place, and that's the University of Pittsburgh Medical Center in different capacities, and that's kind of where I started, and it's still where I currently am in regard to my journey, if you will, of seeing specifically these hip issues. I went to physical therapy. I did my graduate and entry level work at the University of Pittsburgh, and I soon went into right after finishing at that time as an MPT program. I went into a sports physical therapy residency, and during that time, I was fortunate that we had a surgeon named Mark Philippon, who's pretty he's maybe the best known, surgeon in terms of athletes and hip arthroscopy. And he was at our center. So, it wasn't a well-known procedure at the time. He was one of the pioneers, who kind of pushed that procedure, particularly in athletic individuals. So I had a very dense and focused exposure to these patients. And I had a mentor named Pete Dreyevich, who I believe with the Jacksonville Jaguars now as a physical therapist and athletic trainer. And I was fortunate to learn from his experience and see, at one point, almost all my patients, that's still the case, but at that point, they were almost all post-operative hip patients, and getting a very focused exposure then opened up opportunities to teach, at the academic level and continuing education, and then publish. And, over the last 20 years, that's been my primary clinical focus. It's now expanded into, as you go on in the career, you kind of take on administrative roles and, and directing a residency program and administrating all 5 of our residency programs and being involved in our professional organizations. But almost everything I do clinically always comes back to a hip specific emphasis. So it's been quite an experience being part of, but also learning and watching the evolution of what we know and what we do with individuals, athletic individuals with hip pathology. And it's also kind of humbling because for all that kind of work that you put in and then advances that you make, you also realize just how much you still don't know.
Yep, the Dunning-Kruger effect continues to hold true. You think
Exactly.
You know a lot, and then you get involved, and it's like, wow, I really don't know as much as I thought. And
it's people say expert. I don't know if we even have we can qualify as an expert. We just have people who have been exposed more, I think.
Yeah, I continue to find myself in that situation here, actually. And, one of the things I really like that you mentioned is, you've kind of received a lot of different input from a lot of different individuals, right? You mentioned an individual who's now with the Jacksonville Jaguars, so obviously a little bit more football experience. You also mentioned the name of Dr. Philippon there, and I believe he's out in Vail with the Stedman Clinic, or maybe it's Stedman Philippon Clinic.
It is.
So, certainly some great individuals, and I believe they're very well known for skiers.
Yes.
Which, as someone who comes from a skiing background myself, I'm always interested to hear names like that be shared. So ultimately, I kind of like how, what you're explaining to me is your approach is kind of like you, but it's also standing on the shoulders of these giants that came before you and helped impact, who you are today and how you do things. And I think that's ultimately kind of where we need to go in the PT profession, right? Like, so how do you kind of just starting out here, how do you apply that to the hip? I mean, it's a complex joint, ball and socket, moves in all crazy directions. We see some wacky pathologies there sometimes. So how do you go about just kind of like initially looking at the hip joint?
Yeah, it's a good question, and and that in my personally, I think for me has evolved over time, and I think when you look at the way we would have if we published an article 15 years ago, the way we describe it, and it's changed much, and that's across the spectrum, right? That's what we talk about in physical therapy, which I think I would say I'm proud to say that we've expanded that as a whole, the way we look. It's not just all special tests now, right? We have a much more of a movement based emphasis. But across the board, our surgeons, our athletic trainers, even strength, strength and conditioning specialists, as we look at that team approach. And one of the major the things that we always emphasize is, first, you better make sure it is the hip, right, that's causing these issues that you see. It's a basic thing we talk about, probably day 1 or 2, and at least in many musculoskeletal sequences and entry level training, that having the ability to organize your examination that includes a lower quarter screen, spine examination, SI joint examination, other non-musculoskeletal causes, is a very good starting point, because the hip, that region, is very complicated, very hard to visualize. You don't see the hip joint, not many palpable structures there. But if you think of all the influences of all the structures I just mentioned, they all intersect in that area. So as a clinician, young, old, experienced, not experienced, you're really going to frustrate yourself if you don't have this very organized approach. History, again, that's often emphasized in anything that we look at, that history is a large component. Here it is particularly useful when you sometimes don't have the hands-on ability to palpate structures or to really touch those structures. So the history is very beneficial. It sets the course for the rest of the examination. So step 1 is just determining that it truly is the hip that you're looking at. And then step 2, related to that, is often, because the truth is, in clinical, the clinical reality, you often will not see just isolated issues, right? Sure, the hip may be an issue. And this is where often we have to talk to our surgeons, because you're going to find on almost anybody some sort of bony issue there, right? Or some sort of radiographic issue. Impingement is a good example, right? That's really just morphology. Is it really pathology? Is it coupled with symptoms and dysfunction? So, being able to look at all the areas that potentially qualify for someone's presentation, and then systematically rule them in or out, and then prioritizing, is the hip really what we're going after here? And then determining what it is about that hip that is really problematic. That's where discussion with our surgeons and other people of the, other members of our healthcare team, it can be helpful. Maybe they need imaging. Maybe they don't. Sometimes they already have it when we see them. And then that's, what does that imaging mean? We don't want to overemphasize that, and how we communicate that to the patient. So that's where that team approach is very important, because if one cog of that wheel is off, then the patient either becomes confused. Sometimes it doesn't buy into the process. So that really, again, comes back to emphasizing that teamwork approach.
Yeah, I love that you bring up the teamwork approach, and I also love that you emphasize the systematic importance here. Is ultimately, if you want to get better at something over time, you kind of have to repeat it over and over and over again. And while there's value in individualizing each assessment, I still do that. I say that as someone who's still young and learning a lot, but I still individualize each assessment in a way that I'll throw in different things after my normal rundown, but my normal rundown still looks very similar. And I think there's value in having some repetition. There's value in going from gross movement to isolated movement, or vice versa, and picking up the trends over time, because as you mentioned, if we can't repeat it, how are we going to improve in it? And at the hip, it's kind of a complicated joint in the sense that you could have lumbar spine symptoms causing hip pain. You could have SI joint. I know it only moves 3 millimeters or whatever, but it can still cause some issues.
Sure.
So you can have the SI joint contributing to hip pathology. You could also have issues at the knee or foot and ankle contributing to pain at the hip. So it's kind of difficult to look at this one joint that's kind of smack dab in the middle of everything and kind of really get a look of everything if you just go at it in an isolated alone approach. So I guess, how do you go about like looking for things to rule in or rule out other areas of involvement, right? Like, if you have someone's imaging report, it says, yeah, they've got hip impingement, but your exam says, hey, it's coming from the lumbar spine. It's not like an impingement only. How do you kind of approach those situations where the imaging might not exactly correlate with what you see clinically.
Yeah, that's important too. It's sometimes it's the way that you approach it, or probably more so the way you have the conversation may vary depending who you're working with. I mean, unfortunately, I work with all the surgeons I work with. I pretty much know, and so the first thing I don't do is just bust open the door and say, hey, you're absolutely wrong. The hip's not, despite what the imaging says. But there's could be a nuanced conversation even with the patient on this. So we'll look at the individuals. Obviously, their characteristics of pain presentation. Where does it hurt? And this isn't not put on anybody, but I think our surgical colleagues have told us that they've learned a lot from the physical or physios, depending on the country, and therapists, and looking at the whole body, where sometimes they don't. They just don't have time in the office, or it's just not on in the surgical wheelhouse. But when we look at symptoms that are inconsistent with hip issues, location of discomfort, aggravating activities that imaging may have a large, we'll call it a bump, morphologically, but the activities that bother them just don't correlate with the typical things you see someone who has femoral acetabular impingement syndrome or FAIS. Other concurrent symptoms, back, SI is a big one that you mentioned. I could tell you, and my colleagues would tell you the same thing, that it wouldn't be unusual for us to get a case, comes in, athletic case, hey, I have hip impingement, it's all on a radiograph, I'm in, decent amount of pain. They point to their SI area. So it's like, we're going to evaluate this session. We may manually treat that this session, go over, a corresponding exercise, a more appropriate SI joint. Let's come back and reevaluate your hip a week later and see where you're at. I mean, there are times when they come back and not in pain at all, right? It was the SI area, but they went to a specialist who looked at their hip, and there was a bony issue there on radiograph. Not even an issue, right? Just a variation. So what we need to do first is listen. Go look at quality of movement, look at reproduction of symptoms, and are they consistent? What we know, occurs in that area when that's problematic. The imaging is great, but I probably wouldn't even need it in cases like that. And many of us are practicing, thankfully, in direct access where we wouldn't have it anyway. So, the listening component and looking for what makes sense for what we know, right? Or when you see multiple areas involved, I asked, what's your primary complaint here? Yeah, the hip's a little sore, but what was sore? What was uncomfortable first? What is your primary limiting factor? If they're pointing to, for your example, the SI joint area, we're going to look at that and treat it first. So I always stress to our residents, don't be afraid, or don't be hesitant to almost do a multi-staged evaluation where you prioritize what seems to be worse in terms of the limiting factor, treat it, come back, reevaluate it. It's going to save, one, it demonstrates why you're prioritizing certain areas to that patient and to yourself. It makes it a much less frustrating process, as opposed to kind of sometimes a whack-a-mole approach where you're trying to hit everything in one setting. You shock, and you unintentionally kind of shotgun a bunch of treatment interventions. Then if they respond or don't respond, you still don't know which one was most or least effective.
Yeah, no, I love that point. And I think that's where the test method, as you mentioned, really holds a lot of value, is just really using your exam to not just come up with a hypothesis as to why someone's in pain or why someone's seeking physical therapy, but actually confirm it, right? Run your trial. I know N equals 1 in this case, but run your trial, try your interventions, and then retest and see what the outcome is. Because if you get a favorable outcome in a short amount of time like that, I'd imagine the rest of the treatment plan really kind of falls into place. But if you can't nail it on day one, then you're going to be sitting there kind of shooting blindly, expecting something's eventually going to stick. And ultimately, I think it's tough to learn as a clinician if you don't have a purpose for every action. And I also think it's not necessarily the best use of your patient's time and or financial resources to be seeking a clinician who doesn't have some kind of plan in place as to what is going on and, how to assess it or how they're going to proceed. You don't have to know everything. I certainly don't know everything right now. And there's some plans that, change as I get through there. As I'm going through the plan of care, I adjust things or new things come up. I'm far from perfect myself, but I think in general, having some kind of understanding of this is what I believe is going on, this is how I'm going to take care of it, goes a lot more than just kind of shooting willy-nilly here. This isn't the Wild West, unfortunately.
And it also helps you, make referrals, in the other direction, right? So I'm seeing somebody, I've gone through my toolbox of things I can do that I typically see or even don't typically see. None of them are lighting up. And then, at times I'll say, well, you know what, maybe we do, maybe especially in the direct access setting, maybe it's time. And you see an individual outside my domain because, let's use a surgeon or specialist, for example, orthopedic specialist, and a physician because I haven't made you better, but I've done everything I could do. I can tell you, and I can sit here in front of you and tell you exactly what I did, the areas I usually treat in my intervention has helped. That even includes within our own profession. The hip is close, to the pelvic floor. Sometimes I'm referring out to our pelvic floor specialists. That picture becomes more clear when I realize what I typically do just isn't helping that individual, or at least not to the point that they're satisfied.
Yeah, no, I completely agree. And that's where having a good network certainly comes into play
Yes.
as well, because if you don't know those people, it's certainly more challenging, I would say.
Absolutely. Yeah.
So, we mentioned the SI joint a couple times. How do you go about looking at the SI joint, and how do you kind of look to differentiate that from the hip? I love
Yes.
the Laslet cluster personally, but I
Yep.
recognize that a lot of the Laslet cluster tests overlap with some of the hip tests, such as like a Faber or thigh thrust. So how do you kind of go about differentiating SI from the hip?
Yeah, you actually spelled it out. Your clinical rationale that you just kind of summarized there is really the way that I look at it too. So we have our cluster of tests that we know are, well validated in the SI joint population. So for me, again, location of symptoms, and I ask them, is that their primary, location of discomfort? We take them through a number of those tests that are well known through SI joint. What I will do is often modify, as you just discussed, the Faber and other tests that utilize hip, either range of motion or potential compression. I will probably move those further down the list in lieu of other tests that just don't involve the hip. If I can bring out, and not that I have a particular cutoff because I don't think it's been researched, but if I can recreate consistent SI joint patterns in tests that have minimal hip involvement, and then, the simple question, is this your primary pain? This is why you're here to see me, right? I'm pretty confident then that the SI joint is my primary and I go after that. Now, it gets a little murky at times, and this is where it just, at times there isn't a blueprint for this, where you start applying a number of those tests that are designed to, bring on symptoms of the SI joint. You think of the Faber, it's been used for a million different things, SI joint issues, hip issues. It's been described in literature for gluteal tendinopathy. Then you have to really look at how you interpret that test. And again, it comes back to me saying, where does this hurt? Is this your primary complaint? And then I have to know that's your clinical intuition, right? And then our hip tests go back and they'll go through those, at least the screening component. And most of those are better screening tests than they have specificity anyway. And, again, you kind of weigh it out. Am I getting, hip and SI joint tests, one's positive, the others aren't negative? That's a pretty easy decision. If they're both coming up positive, then that's a discussion with the patient. Which pain here is primarily why you're here to see me? That's what we're going to go after first. The reality, especially with the hip and the SI joint, is the prime example. But, general low back pain in general is often you will get those individuals that will kind of light up on both tests. And that's when you have to prioritize, what you're looking at. Now, I will also add in, then we look at their movement quality. Because sometimes when it comes down to treating movement, that would be something you would do for both those populations. So if they have a terrible, the tests you look at in the hip literature are no different than the knee and many other motor control on step down, single leg squat. If we see that is faulty, correcting that or addressing that as a movement impairment, ideally you would think would benefit both of those issues if they were having both.
Right. You actually kind of led into my next point there, is I'd imagine just because of the anatomical similarities between the SI joint and the hip, I mean, the glute muscles run to the greater trochanter area from the sacrum. And, there's like the deep six external rotators come into play as well. I know you've done some research on greater trochanter pain syndrome. I know you've looked at kind of that glute tendinopathy and also like micro tearing of those tendons as well, because while we think of like rotator cuff tears, we often don't think of that as it applies to the hip, and these muscles essentially rotate the hip. So I would imagine that some of those exam overlaps, when you see some positive SI joint and some positive hip, I'd imagine that might lead you to kind of look in that area of the similarities between the two. Yeah.
And that's where, even if you look at the literature, for as much as we have, admittedly, this is, younger literature, if you want to call it that, but, that's kind of a link that you can see. We know individuals now, again, depending on the age group, not as well researched in athletes, so there's emerging literature looking at it, but think of gluteal tendinopathy or greater trochanter pain syndrome, GTPS. Those individuals with gluteal tendinopathy, there's a high proportion of them that have, the majority would almost say, either a low back issue or a hip issue. And now in the older population, it's hip OA, and that could be your older active population. Doesn't just mean non-active people. And they have back issues. So they're almost, because of their anatomical proximity, often they're inseparable, as you get a package deal with them as the clinician. And it makes sense, because if you think about it, if you have one issue or the other anatomically, your back, SI, let's say, or your hip, having a failure of your gluteal complex, and if it's massive, that's pretty straightforward, because you can see why someone has a giant pelvic drop in their walk, and you're going to have issues both areas. But even subtle in let's say our more active population, where maybe it becomes an endurance issue and their performance and such decreases over time during, let's say, a session, or if they're running, whatever it may be, then those other areas in proximity, back SI complex, hip joint, they're going to pay the price. So often the underlying the common denominator between a number of these processes, these anatomical neighbors, is the soft tissue performance, that strength, or I'll say strength and endurance. Sometimes not a one rep max issue. It's, what do they do over time? And do you see failure within a session or sessions of, especially endurance athletes, where we see a lot of the gluteal issues occur?
Yeah, exactly. And, you bring up a good point there as well. You mentioned the Trendelenburg sign and Trendelenburg gait. And that seems to be an example, at least from my experience thus far, that correcting that certainly helps alleviate symptoms long term. Is there a limit to the movement screen or movement assessment, and how functional movement applies to, pain? Like, can you think of any examples where, someone showed a compensatory pattern, but correcting it didn't really change anything?
Yeah, and I can use a few examples, because and I'm going to use the hip population, obviously, in this case. The one good thing I can say is that, in the last probably 5 years, even more, we've always, as physical therapists, we always emphasize movement. We should. We always put a high value on it. It's the unique part of our profession. I think I don't say we own it, if we own anything, but we're trained in it more than anybody. Better than anybody, I would say, with corresponding detail. But there's literature now that shows in the non-arthritic hip pain population, which is the name we term to say that would cover most of our active individuals with hip pain, whether it's dysplasia, FAIS, etc. The movement quality, or the importance of movement, has been now shown in the literature. It's starting to emerge in terms of what it means for outcomes and such. However, there are things you have to consider there, that at times, people's movement, it may be compensatory and it doesn't look optimal, right? Of what we think is optimal for athletic performance, but there may be some reason. So give you two examples on opposite ends of the spectrum. Impingement patients, we know that we look at them do a single leg squat. You will see that they tend to, often, if you look at it as a subpopulation, their pelvis will often tend to tilt forward as you go on that squat, and they'll close down that angle faster at the hip. You can see it creates an end range, earlier in the motion, and we think that correlates with some of the pain that they're experiencing. And the thought process would be, if you correct that, so to speak, by whatever means it is, whether it's feedback, whether it's strengthening, or some combination of all those, to improve performance on that because they've controlled that pelvic tilt in the sagittal plane, that they should be less painful. And often that is the case. But you have to also remember, some of these other hip conditions are in the spectrum. So what we sometimes see is people who are a little less stable due to a dysplastic hip. And when I say that, I don't mean the childhood the pediatric dysplastic hip that becomes very, very relevant, becomes very apparent early in childhood, severe, needs other, maybe the more borderline dysplastic hip that does pretty well because it gives you mobility, but over time starts to cause issues for the individual. They may favor a little bit of an anterior tilt because it provides a little more coverage to the femoral head. So, for those individuals, we start tinkering around with it too much. And sometimes what we do is we bring them out of a little more, we take them out of a position that gave them a little more stability, right? And we actually make it symptomatically, could make it worse. It's a nuanced conversation. These things, you can't always see this happening, but there's an example of working towards what we think and what we know is optimal movement, but in some particular situations, maybe it wasn't the optimal movement. Maybe it was actually serving them well, just through their anatomical capacity.
Yeah, and that ultimately goes back right to where you started off on the importance of the subjective component. Is ultimately, if you don't understand who you're working with and what they need to do, then you might fall into that trap, right? Like, maybe I see someone who's in a slight anterior tilt and a little bit increased of, lumbar lordosis, for example, but then I understand that they're a gymnast and they need to back bend extremely far and do all kinds of crazy flexible things that I can only dream about doing. If I go about correcting that too much, then how does that impact their performance on an athletic side?
Right.
The other piece too is, at least in the athletic population, and I'll venture to say that athletes are not limited to a certain age number. They can be across the
Right.
population. Athletes are ultimately master compensators. They will find crazy ways to hide things. And
Yes.
ultimately, it becomes a conversation of what do we correct, quote unquote, correct or not correct, because maybe that compensation helps them athletically, right?
Right.
We'll take a broad example here, a knee valgus, which, yes, it's at the knee, but ultimately we credit that largely being a hip problem, lack of stability at the hip. And we look at that as always a bad thing. But then we watch basketball players go into that position every game, or power lifters who are squatting 800 or 900 pounds move into slight knee valgus, in my assumption, to get a better moment arm and angle for their hips, their glutes to produce force to get out of the hole of the squat. And they're okay. They're not getting hurt every time or anything like that. So it
Right.
becomes an interesting conversation, and it's always like a hot topic thing I find on the movement assessment versus on how much is too much, where do we correct versus not correct. And ultimately, I think it always comes back to the case-by-case scenario. And if you don't do a good enough job listening to your patient and understanding what they have to do, then, as you mentioned, you could do them a disservice trying to correct something that doesn't need to be.
Yeah, and it's often a conversation too, especially as you get into the organized athletics and higher level. You have to make sure you're mindful of, they're likely, especially these days, even younger kids, working with, a coach, a trainer, someone who may or may not know these issues, and there may be a conversation to be had there where, you want to make sure everyone's on the same page. And you never want to have conflicting. You want to minimize conflicting messages to a patient, just because it's, the quality of patient care suffers then. And also, the relationship, for good reason, often, if you're giving advice that is contradicting what their coach, who they probably have a very good relationship with, their advice, one, you're going to lose that a good bit of the time. Or if anything, you're going to set up a conflict where then you have to force somebody to decide, and I think of, I don't treat a ton of golfers, but the one thing you'll never see, but I used to, when I used to see more of those types of hip injuries, and you'll never hear me giving out, I'm not a very good golfer, but you'll never hear me giving out golf advice, right, on what someone should do. I'll give them an educational, description of forces, what they do. So maybe this is something to discuss with your, your golf pro, whoever you're working with, your coach, but, drawing a hard line sometimes is really going to put everyone in an awkward situation, and it may not get you the clinical result that you're looking for. Now that does very little bit post-surgically and such, where maybe it's just not time to do something, but that's a whole other conversation versus where performance meets rehab. And that line is sometimes blurred.
Here's where you and I differ, Keelan. I actually give out the golf advice. I tell them very explicitly what not to do, because
Yeah.
I golf like I should bowl, and I bowl like I should golf. Golf for me is a high score wins kind of thing. But no, I completely echo your point of the importance of collaboration, because ultimately we can't know everything.
Right.
We can't expect to be the golf coach and or the hitting coach and
Right.
the movement expert PT and the strength coach and the mental health resource and the sports dietitian. We can't expect to do everything ourselves. We can wear a lot of hats, but we run out of room eventually. So I think that there's certainly a lot of emphasis that needs to be placed on collaboration with all of those individuals, and ultimately just kind of having discussions like, hey, here's what I see. What have you noticed? Because
right.
you might notice something, and that coach might say, hey, actually, I noticed when they swing, they do this, or something along those lines. And you might actually find you've kind of seen a lot of the same things, just maybe didn't realize it. And
absolutely.
Earlier, you brought up another interesting point on the micro instability of the hip. And that's something that I'm certainly seeing a lot more myself clinically. I see, a lot of younger female athletes who have this a really crazy motion. I can grab their hip and internally rotate it 90 degrees almost effortlessly. And meanwhile, I look at myself, who gets 20 on a good day, and I'm slightly jealous, but ultimately I'm seeing a lot more of those instability cases at the hip run around. And it's always interesting to me, because we've talked about shoulder instability clinically so much, but I don't see the same instability concept applied at the hip too often, or same thing what we talked about before with the micro tears. Do you feel that like a micro tear at the hip would go hand in hand with instability? Or do you think that, instability is just a general strength thing? Or how do you kind of see the concepts of instability overlapping with the concepts of soft tissue involvement at the hip?
Yeah, when you look at it, hip instability, you could kind of put in a couple different buckets as well. We're releasing our, hopefully up the next 2 weeks here. We're just waiting for the editorial process to go. We're releasing our clinical practice guidelines, and we have 7 or 8 authors on there. I might be off on that number, but a number of authors. And probably the greatest challenge we had in agreeing how to discuss it was hip instability. Unlike the shoulder, which probably has more literature and it's probably a little easier to define. And the issue with hip instability, you have large amounts of instability that are usually identified, and that's your dysplastic hip, shallow cup, so to speak, and that hip's going to be very unstable. And there's, it's a whole conversation that's probably often one we're not having unless you work with pediatrics, etc. And then you have the term that I utilized when we were discussing it, and you'll see a rise in the athletic literature now, is micro instability. And the reason that's very relevant at the hip is because it truly defines the clinical entity of instability. So it doesn't just mean your hip's loose, though that can be part of it. There are plenty of people with kind of loose hips, so to speak, that don't have issues. It's a clinical entity of pain. Unlike the shoulder, you may or may not get some of that apprehension and may feel, unstable to them, but often it's more of a pain issue, not as much of the actual feeling of not supporting you. It's just due to the fact that even an unstable hip doesn't move to the massive amount the shoulder does. It's an anatomical, variation there. But when we use that term micro instability, what we're suggesting are, a number of subtle features of supporting tissues of the hip, and that could be the ligaments, the labrum, that provide stability to it, and being affected in a way that affects performance. So when you look at that particular group of individuals, there's the group who you were describing. My daughter's a dancer, so you see a lot of these individuals. They're just lax all over. I mean, they're lax in their shoulders too. So there's part of your issues. Sometimes they have shoulder and hip issues, etc. They're going to score high on that Baton scale, just shows universal laxity. They're going to tend to be lax at all joints, and the hip is no exception. So they potentially can have issues. They often do well because you see them. They just often do well with the strengthening program because they're probably not doing it a good bit of the time, or a strengthening / and with a neuromuscular control program. Then, if you want to make a comparison to the shoulder, you'll also see the group of acquired microinstability. Think of your golfers who we don't typically think is the most flexible group of people, but it's what I saw a lot early on in my career, especially when back then, which was long enough ago, golfers weren't the athletes who are now across the board. Now a lot of them are training, they're trained like athletes the way you'd expect them to, for good reason. They can acquire a directional micro instability, basically meaning that, through forceful driving of the ball, in this case, they externally rotate the hip, loads the femoral head forward, and over time you attenuate the femoral ligament anterior structures. Think of that as your unidirectional shoulder instability. At least, there's a comparison there. Again, those individuals can do well with rehabilitation, but it may change your concept in the way that you treat it, because they are only particularly lax and then clinically unstable in one area. So you see the subtle variations. You can often, there are ways you can pick that out through the examination. And then it still comes down to your impairments, how you treat them. You look for, weaknesses that may be present, imbalances that may be present, and then also hoping to fuse that together along with the strength training into a movement control type of approach as well.
Yeah, you bring up such an interesting point with the dance population, so much so the timing is impeccable, because we've just published a episode diving into dancers and dance medicine with a dance medicine specialist. And, I believe that in order to do some of the positions that they get into with the extreme external rotation, the straddle splits and different things, I believe there actually has to be micro tearing of the iliofemoral ligament just to allow it. So,
yeah, it adapts over time. There's a good example, right? You'll find some of those individuals that are whatever test you do and such, especially moving forward, they may come up positive. Not so much for pain, but that you would say that is an excessive range of motion or mobility. It probably isn't great for a good bit of the normal, quote, a normal population in terms of potential things that could happen there. But that's where performance is going to require. What it requires sometimes isn't the most ideal for the average individual, but it's going to be there, because if it isn't, they're not going to do it.
Right. Before we get into the intervention side for that, because I really want to dive down that, I got to ask you too, we talked about SI joint special tests and clusters. Other than I believe there's a clinical prediction rule for like hip OA, is there anything along those lines for younger individuals as well? Because, at least from my standpoint as a young clinician, we do our gross movement, our isolated movement, we get our strength, our range of motion, our impairments, then we look at our tests. There's some that I like, and there's some tests that I really don't like. For example, I have never really felt like good outcomes from like the log roll test where you just roll the femur in. So is there anything that you kind of look at on your own from like a more validated clinical prediction rule or just cluster of tests that really speak more value at the hip?
Yeah, so that is a good point, and if you look at where the evidence lies for these, the one thing we know across the board, whether it's good or bad, is that particularly in the younger non-arthritic, I say younger only because eventually, because the non-arthritic becomes arthritic as you go on with age, if they've had those issues in a decent amount of people, especially if it's dysplastic hip. But let's just say in the non-arthritic hip pain population, most of the tests that are out there and that are described, there's so many of them, and there's no reason to go through every single one of them. We use the flexion, adduction, internal rotation test, the most well-researched one, as a prime example. But throw everything else in there, they're almost all better screening tests than they have specificity. So that meaning it's a lot easier to rule it out than to rule it in. So often what we do is we literally try to do that. You look at other kind of what maybe low-hanging fruit. We have pretty good descriptors and clusters tests that are validated for the hip OA population. So often I'll take a look at that first just to make sure, especially in some of my people who are, and I include myself in this population, hey, they give me their 30s and 40s, you start developing hip OA. If you see an actual large loss of internal rotation, they may have impingement on a radiograph, but it is also a good chance of losing joint space and such. They're becoming that arthritic patient. So you start looking at marked loss of internal rotation, specifically flexion, then you're already moving well down that path. Then you may be looking more at an OA patient. Doesn't matter if they have what the radiographs say and such. They're losing true joint mobility. We will use our hip impingement tests if those tests for FAIS don't come up positive, because they are good screening examinations. You can start to move towards other causes of their pain. They're good screening tools. Now, if they're positive, the only thing it doesn't tell you is, that could also be OA, it could be a stress fracture, it could be many other things. So there's not a real well-defined test, but what I look for is age. They're going to be relatively younger. I rule out, the potential for OA by those validated cluster tests that we use to rule in hip OA. I'll go through a few extra articular tests to elicit pain, because typically those don't elicit pain, minus maybe hip flexors for the non-arthritic hip pain population. And if I have that positive test that is a better screening test and nothing else is coming up, then it increases my, that's what I'm looking for. It increases my confidence that we're looking at, I'm going to use impingement because that's what everyone's focusing on in the sports medicine literature, that we're looking at impingement. Other tests, like just the log roll is an interesting test. Not a ton of data on that, but if you have a bunch of people based on where they do a lot of these studies, they're out of hip preservation centers and such, that they're going to see a ton of these patients. So if you have a room full of people with hypermobility in front of you, you're probably going to find a bunch of positive log roll tests. It goes out more one side versus the other. It gets a little murky. You see the general population coming in, all sorts of different diagnoses. They're not selectively being funneled to you. There's not a lot of research to show just how accurate those tests are in that case. And that's probably where most of us function, somewhere in that space, versus having, most of us aren't sitting there, even myself, and I'd be more likely than most people. I'm not getting 20 hip people sent to me today that probably have FAIS. I'm getting a variety of different diagnoses. So the research to support these is often, you have to take it with a grain of salt because of where it's coming from. And that's just, that's where the literature stands. And we kind of try to reflect that in our clinical practice guidelines when we make recommendations.
Yeah, definitely. I like that kind of rundown there. And, I guess I have to say I lied earlier because you brought up such a good point that I need to hit now. You mentioned that it's difficult from a test standpoint to pick up on something like a hip stress fracture. And that's something that we definitely see in a lot of the younger athlete populations, especially. And as far as I know, there's not really one good thing you can do objectively to kind of look one way or the other there. You have to listen subjectively and get a good history, but ultimately that's one that you would need the radiograph to confirm. I mean, I've had some in the clinic before where, I do the percussion test, the auscultation test, and that comes back positive. So I'm like, okay, I think we're good. You break out your little tuning fork. I've thrown the phone on like vibrate mode before and hit different areas. So I, at least from my own standpoint, I haven't really found anything good to detect those. Would you say something similar?
Yeah, it's funny. I always joke that in Pittsburgh, if it's February through the end of March, and you have someone come with hip pain who's a runner, automatically 50% increase in my likelihood to think of stress, just because they're all training for the marathon, right? So the history is so important here, in these cases, because because if not the majority, depending on the environment that you work in, a great proportion of these individuals, it's going to be a ramp up that just overloaded the bony, the structural capabilities of the bone related training. You're only going to pick that out from history. Now, what I'll look for then is evolved. One, do they have a history of any other hip pain? No. Did they ramp up their training? If there's any nutritional background and such, or other, considerations that we have to take into consideration, other factors. But in pain that has increased in relation to training, that is only getting worse over time, the historical component is so big. And to your point, if any of the tests that I think potentially could, and none of them are great, I know there's a little bit, the literature, the single study or a couple studies on the repercussion test look good, the patellar percussion test, but really in clinical practice, as you've noted, it's hard for me to sometimes really interpret that. And I've been wrong many times, saying I thought it was positive, or I thought it was, indicative of potential stress fracture. But to me, I set my threshold a little lower for these individuals because of the cost of missing a stress fracture. So if I'm the first person to get eyes on them, and even a couple of these things are making me suspicious and the history warrants it, that's where I'm a little less hesitant to send them to at least to someone to get looked at. I do know a case, I didn't miss it. No one actually missed it, but it always haunts me, of a young lady who had the symptoms, signs. She realized that she was walking up to she finally decided, I'm going to go see the specialist. I saw her after surgery, so this tells you where it's going. Was walking up the stairs to the orthopod's office, and her hip completely fractured on the way up from a stress fracture. A runner, right? So I think about it, I was like, oh, that I do not want that on me, and I don't think that, in this case, there's justification. You don't want to be, you don't want to be overzealous and referring everybody for something. I don't do that with labral tears. I don't say, oh, I think of labral tear. You're going right to the physician. You need imaging. So, because the physician's not going to, or surgeons aren't even going to do that. They're going to say, well, we put you through rehab anyway. But in the case, I suspect a potential stress reaction, stress fracture, other than the activity modification recommendations, I've set that threshold a little lower to referring those people, because I think the outcomes of missing it are just, they're so much more severe.
Yeah, no, I completely agree, and I love that you bring that up, because it only takes missing one to kind of realize, like, oh, this is not good.
No, it's not a good look.
Thankfully, knock on wood, I haven't had that happen to me. Well, indirectly, we had that happen. We had a patient who saw me for physical therapy and an ortho doc. They were kind of holding on the MRI because she was getting better. And, this individual got back to the point where they were doing quite a bit physically without symptoms. So it was kind of one of those, like, at least for me, it caught me off guard. Because typically those don't improve.
Right. No, that's true. Yeah.
So anyways, finally onto the intervention side of things here. I think that the exam, the evaluation, your assessment is ultimately the most important, because like we mentioned, if you don't get you might not get everything on day one. You might have to look at some other things later on, and that's fine. Things might change, and that's fine. But ultimately, you have to have some general direction of what I need to do and where I'm going to go.
It'll drive your intervention.
Right, exactly. So on the intervention side, what kind of things do you like to do? And I know that's a very broad general statement here, but when you think of like core stability being important for the hip, what are your go-tos for a core stability standpoint? When you think of hip stability or micro tear in, one of the glute tendons or something along those lines, where do you typically go with your interventions? Are there certain things you like, certain things you don't like?
Yeah.
They open chain, closed chain. Kind of walk me through what the typical Keelan, intervention plan would look like for some of these different things.
Sure. And I think about, I guess I'm semi excited to say in our new CPGs that will be published free, free access to JOSPT, but they're CPGs, so they're free access. One thing we found, looking at the literature, and I'm glad, and I think most of us practice this way, so I don't think it's something that should be a big surprise, is that it supports a multimodal intervention. Now, when I say multimodal, what that means is the programs that have shown improvement usually have a mixed component of strength, some mixed component. Now, what it is exactly, that isn't as well defined yet. We just haven't, the studies aren't that high quality, but a combination of strengthening, motor control, joint mobility, that may be manual therapy or other interventions, in neuromuscular control, all employed together. And so I guess, what that tells you is, you should at least go into the intervention, the thought process of thinking of of expecting that you may have to use, different things in your toolbox, which I think that's not different than anything else that we see. Strengthening, if you look again, the literature shows that these people are weak. And I'm talking about your athletic, non-arthritic hip pain individuals. They are weak, and where they tend to be weak are the gluteal muscles. No surprise there, right? And the rotators. Now, what I'll say, clinically, I think we across. I don't want to generalize, but I think I can in this case. As therapists, we go right to those gluteal muscles, right? We think of that all the time for many different things, not even just the hip, and rightly so. And I think we do a pretty good job of the basic interventions there, right? I think what we sometimes don't think of is transverse planes. So those are those deep rotators. Think of your athletes, a good majority of your athletes, especially field athletes, martial artists, etc. There's pivoting of the fixed femur on the pelvis. The pelvis on the fixed femur to some degree. And so what we'll often do is we'll train rotation. We'll see people sitting there doing internal external rotation of the band or something isolated. That's good, if you want to kind of wake those muscles up, strengthen them even. But at some point, you got to get them in weight bearing and probably in double and then single limb weight bearing and rotating the pelvis on the femur. So I always make sure, and that's also true just activities of daily living. So I'm not just talking about elite athletes here, but I make it a goal to get to the point where we can perform exercise with individuals on one leg, and they're required to rotate the pelvis on the femur, kind of open it up as a term I'll use the patient, or close it down, but open it up as your external rotators, deep external rotators active, while maintaining frontal plane stability. It's a simple process when you see them do it. It's not the hardest thing to show. I put a lot of words to it, but it's really transverse plane motion, created in a way that all other planes are controlled. So you're not rotating and dipping down on one side and corkscrewing your hip. That's just not good for the hip, for one thing. And so my progression of the strength program always works towards function, right? That's what we're looking at. At the same time, you can't just jump to that right away, because if they haven't met the prerequisites of they just aren't strong enough to even control single limb stance, probably shouldn't have them rotating on that leg without meeting that prerequisite. And then you also have to determine, is it a strength issue, or maybe their motor control is just not good. And then your strength program has to be supplemented by an appropriate motor control program. It's just a little bit of intervention approach. It's not just strengthening, it's feedback, tasks, mastering tasks, etc. So you can run those both in parallel, but you just don't want to jump the gun and start to where you want to get without covering the prerequisites first.
I love that you bring that up. Ultimately, it's earning the right to progress. And right. Ultimately, as you mentioned, your interventions have to be complete in the sense that you need to address everything. I can't tell you how many times I've seen this from other individuals. And I'll admit, when I was in PT school going through my clinicals thinking I ran the world, I also made the same mistake. Basically they would look at the hip flexors and say, well, it's a positive Thomas test. The hip flexor's tight. But they also would look at hip flexor strength and it would be super weak. So we would treat it by just stretching the heck out of it.
Yeah.
And it's like, I'm guilty of that myself. At one point, I think the Thomas stretch was like my answer for everything when I was in school, right? That'll fix it all. But, you can't just stretch muscles and expect improvement. We also have to use some targeted strengthening. And as you mentioned, I would say that 3 sets of 10 side-lying clamshells never changed anyone's life, unfortunately. Right. But there's a time and a place for it. Same thing with the side-lying hip abduction. That's not the thing that's going to take someone from day one all the way to, the finish line. But there's a time and a place for it, right? Even, if you get someone post-op ACL and all they can do is side-lying hip abduction in the brace, in addition to their quad sets, their heel pops, all that kind of stuff, I'm going to have them crush it. I don't want to fall behind on other things like, the hip strengthening. I might not spend a ton of time in the clinic on it because we need to get that quad and extension back. And I realize that's a separate discussion point, but I can't, I can't miss the hip in that, and I think that's something that we often forget, is just because it's not the thing that's going to look super cool and sexy and take us all the rest of the way doesn't mean that we should just completely ignore it.
And you make a good point too. That sometimes the idea is you're teaching recruitment, right?
Yep.
And so dosing becomes an issue when it does become an issue. But sometimes it is a matter of, hey, this is what it feels like to recruit this muscle. Now, if this isn't going to get you where you need to be, then we're going to have to start applying dosing principles. Move towards eccentrically loaded activities. So it's kind of the start of your journey, but you can't strengthen somebody's muscle if they don't know how to recruit it. Yeah. So Once they get a feel for it, then you start the dosing conversation in your athletes, and then you start really pushing those principles.
And I'll even venture to say that, a sideline clamshell or a sideline hip abduction is not inherently a strengthening exercise. So you're not going to get as much of as you mentioned, you're not going to get the same dosing and load response out of something like that as you would something, more, I use the term functional, but I think anything strengthening is functional. Like if you can compare that to a heavy loaded single leg squat with good form or a heavy loaded single leg RDL, I think that's the kind of stuff that will carry you much further. And I do say the term heavy and loaded together because I think ultimately a big issue we see, especially with the hip, is a lot of physios and even some, strength guys and that sort of thing are afraid to load it. They think, what, I'm doing my clamshells, my sideline hip, we're hitting the core with the bird dog, so we're all good. We're doing the big three, checking all the boxes. And it's like, that's a great start, but can we take it a step further? Can we do a heavy loaded single leg squat pattern, a heavy loaded single leg RDL pattern? How about some lunge patterns with a heavy load and a heavy RNT band? Can we start to incorporate more things into it instead of just saying, well, you've hit the isolated movements, the integrated and functional patterns, that's all going to go on you.
Yeah, we can see that when we have those individuals who haven't been progressed to the point that they should be. All the points that you just mentioned, when we do return to sport testing, this is anywhere, but the hips, I'm just using that as an example because inevitably they're high likelihood of failing their actual return to sport test because they just haven't trained in that manner. They haven't never met that threshold. They've done a lot of isolated things, but they haven't pulled it all together to have appropriate strength, motor control, endurance, and to do it repetitively over a set amount of time. So, ultimately, a lot of those individuals will not do well on that. Those testing procedures, which will identify, which intend to look at those characteristics.
What kind of things are you looking at on a hip return to sport test? Are you, we think of like a knee, for example, and we look at hamstring quad ratio. We look at single leg squat and hops and jumps and all these other tests. Would you say the hip is pretty similar, or are there any different unique things that you like to assess?
It's a little bit of both. There's a lot of similarities, and a lot of that I can tell you is by default. Again, I know in our own center, and I think if you look across the board, we some consensus looks at consensus agreements on this. So we've been published a few of them. By default, we've pulled a lot from the knee. Now, part of that is because when you get to any lower extremity, some tests are just going to be functional regardless of what joint is involved, the ability in most sports to jump, pivot, hop. So we'll pull some of those tests, a lot of those tests over, and they would be applicable anywhere in the lower extremity. So there's a lot of similarities there. And they have admittedly been much more, there's much more validation in the knee, even though even there, it's not by any means perfect. Now, what we will look at the hip is we may bring in, and also this will vary by sport at times. I'll look at some ratios that are a little bit different. So we actually quad and hamstring, those are still good things to look at, but for the hip, ab and adductor strength. So you want symmetry of abductors side to side, if possible, close. They're never perfectly symmetrical, right? But we use a 90% index. There's not a lot of literature to actually validate that. We're just borrowing off what we look at for other lower bodies. The other thing to look at when you look at soft tissue injuries of the hip is the adductor to abductor ratio. I think your hockey and soccer players, there is a lot of literature for this, or is a decent amount. It's been published. And if you're in whether or not you are rehabbing someone with an adductor injury, if it's an adductor injury, then for sure. But even those who don't, because hip injuries will probably potentially predispose you to having an adductor injury. So, that 80% ratio is what you'll see in the literature. It's always a good starting point of your adductor to the ipsilateral abductor. Anything less than that, there's a potential, particularly in hockey and soccer players, risk for injury or re-injury of that adductor complex. That's kind of unique to the hip, only in that you're probably not looking at all your knee and ankle patients. You could, but you're probably not. So that is something that we'll particularly look at. And then again, I look at rotary motions that involve pivoting on that hip. I may add in a couple of tasks that are just that emphasize it a bit more, only because it's a demand of our athletes, and two, it's what we think of as where it's often we'll see failure, coming out of rehab of the individual when they get back to sport.
Yeah, I love that. And I love your point on the ratios and all of that as well. How do you typically test some of the different ratios? Like if you did abductor, adductor, are you using like a isometric device sitting down or laying down, or do you do everything standing? How do you like to test those?
So in a perfect world, which I don't, it's interesting because, I see a lot of hip patients, but I don't live in, when I say perfect world, you have all the devices available that you could. And I don't use, I don't remember the last time. I have probably at some point just tinker around with it. I don't use we have a Biodex machine, large sports medicine. I don't use that for the hip. It's a real hassle, to be honest. And I don't think you get a lot of, the data is hard. You can do it. It is quite the process in clinical reality. In a perfect world, I'd have something like the VLD, like the hip deck, right? The force frame, that all the pro teams have, and a number of my colleagues have in their different settings in athletic settings. Because I think it is a very reproducible way to get hip, ab, and adductor strength. I don't have that either. So we have, handheld dynamometer, or you can even use a Tindac, right? If you don't have that, available, you get kind of creative with it. Now, the testing position, I'll look at it two ways. You can do both, and it's very easy. It doesn't take long because it's supine in both cases. You can go supine hips and knees, flex to 45 degrees. If you look at the EMG studies, that pulls in the greatest proportional recruitment of all your hip adductors. However, when I'm looking to return to sport, I also do it straight because that's the Copenhagen test, that Christian Thorberg out of Europe has described hundreds of soccer and validated hundreds of soccer and hockey players. Now, for that, often though, it isn't the strength that's so important. It's the symptom reproduction. That's how you guide return to sport. So to answer your question, supine, test strength both in hips, flex to 45 degrees and in neutral. And then in that neutral squeeze test, other than strength testing, we'll also look for symptom reproduction. And there's a whole, he describes very nicely on using kind of a red light, green light, yellow light approach of reporting their pain, whether they're really ready to return to sport yet. And he's validated that, or they have validated that in hundreds of thousands of athletes at this point.
Yeah, that's incredible. I love that approach. Keelan, I feel like we've talked about so many different things, from examination considerations to interventions to a return to sport process. Is there anything that you feel we missed, or anything else that you really want to hit on that we didn't yet?
No, I would just, tell people that to realize that this is a very, we should use it as an article title years ago in 2014, and it hasn't changed. It's an evolving process. So I'm excited, especially in the last 5 years, the things that have come out that have been very specific to rehab, for in non-surgical rehab for these individuals. Early on, we put all our emphasis on post-surgical rehab because those patients were right in front of us. Truly, the surgeons have a lot more money than us, so they had the ability to research, post-surgical rehab. They had more of an interest in it for good reason. But now we do have, it's by no means perfect, and it'll change in a year, and 2 years, 3 years. But at least now we're starting to get momentum on non-surgical treatment of these individuals and parsing it out with a little more specificity. And I would tell people, if anything, just to stay tuned, because it is evolving. The things we're telling you today, I don't think they'll ever be obsolete, but we'll be able to get a lot more granular detail on some of these recommendations, such as strength. What do you do? Core strengthening, hip, pelvic girdle, muscle strengthening, movement qualities, where a lot of this is really starting to come to the forefront now. What it means on tests that we've already known have been out there, but what do people with non-arthritic hip pain look like on these tests? And then how do we pair that to intervention? And now we're even seeing some emerging literature showing that if you can improve somebody's quality of movement, you can improve their patient-reported outcomes. And that's a really great to have. That's something, because it's what we do, right? No one else does that. So I think, again, that's going to give us a little more, if you want to call it ownership, or, a little more of a stake, that we can show in the literature as to the outcomes of these patients. And so I'm excited to see over the next 4 or 5 years, and what there's a lot of people doing exciting work here. And I think we're going to have a lot to talk about as time goes on.
Yeah, I completely agree with you there, Keelan. And speaking of a lot to talk about, where can people find out more about you, or where can people find that new CPG that you've referenced a few times that'll be coming out soon?
So if you, I believe, I don't see any emails popping up saying otherwise. I think it will likely formally be published in July, if not the month after that. There'll probably be a sneak peek on the Journal of Orthopaedic Sports Physical Therapy website. Again, also, we always encourage people to be members, but the CPGs are free, like any good CPG should be, to the public to access. And if you really want to get a sense, look at the one we published in 2014, and when the new one comes out, and you may look at the new one and say, hey, we give graded recommendations. There's maybe 1 or 2 A's, a bunch of B's, some C's, some D's, E's, all the way down through F. But if you look at what we had back in 2014, everything was an F. So, if you're looking at it from a report card perspective, it may not be the honor roll, but it's better than we were doing in 2014. You can learn a lot about our work, because if we summarize, not just our work, our attempt is to give a non-biased summary of where we stand in conservative treatment for these issues. So I think that's a very good place to look. and it's free, it's online, and it's meant to give clinicians an idea where the literature stands right now for these individuals.
Yeah, completely agree. So we'll be sure to link to that below, and we'll probably link to some other things too there. Maybe your bio on the University of Pittsburgh website,
Yeah.
or something like that there as well. So that way, if people want to find out more about you, or I jokingly, well, seriously told someone before that we were going to link to his ResearchGate. And he was like,
"Oh
wait,
yeah,
is that still a thing? Do people use
it
that?
is."
So we'll link to all of that below as well. So if people want to find out more about
I do have a ResearchGate account, so you can click on there, and I think it's up to date. So if you want to see any things that we've worked on, and they are available there.
For sure. So Keelan, I really appreciate your time. This was awesome. Thanks again.
Absolutely. Thanks for having me.
Thank you so much for listening to this episode of the Brawn Body Health and Fitness Podcast. If you liked this episode, please make sure to share it with a friend, subscribe so you don't miss any of our upcoming episodes, and leave a review. This way we can spread knowledge and motivation and help reach more people. Thank you again for listening, and I'll see you next time.